Dr. Nascimento is a professor and director of Dental Clinical Research Unit at the University of Florida College of Dentistry. She received her DDS and PhD in Cariology from the University of Campinas in Brazil. She has been actively engaged in the teaching of cariology and of operative dentistry in the US since 2007. Dr. Nascimento has been funded by NIH and IDCR and industry to conduct clinical and translational science research in cariology and oral microbiology. She's a member of the Executive Board of Directors of the American Academy of Cariology and the American Dental Association, Council of Scientific Affairs. She has served as the president of the IADR Cariology Research Group and as a chair and counselor of the ADIA Cariology section. So that's a short bio of a brilliant career. And I'm very happy that you accepted this invitation to talk to us a little bit today. We'll have time for questions in the end of the presentation. So the attendees can go to Q&A or chat, and I'll be collecting the questions, and then we can answer them at the end of the presentation. So I encourage you to just go and write your questions there. Okay, now, Marcelle, floor is yours now.
Thank you. Thank you, Simone. Thank you, Adriana. And thank you to the entire team and group for the invitation. It's really a pleasure for me to be here. All right, so I was invited today to present to you a little bit more information about the two caries management guidelines that were published, the first one 5 years ago and the second one this year. So I believe Dr. Duarte Simone just introduced me and she was able to share some of my information, but as far as disclosures, I'm part of the Executive Board of Directors of the American Academy of Cariology. At the time of publication of these guidelines, I was part of the American Dental Association Council of Scientific Affairs. My research is today funded by NIH and IDCR and Colgate, and I've served as a consultant for several industry, but I'm not in a payroll of any of them, just so you know. So we're going to start this presentation by talking briefly about caries, the caries process, the main information that we are trying to convey in terms of how we manage the disease of caries today. And then we're going to dive into the two guidelines into caries management. So we know that caries is a biofilm sugar-dependent multifactorial disease. It is still a very prevalent disease. The main sign and symptom of caries, the clinical sign and symptom of caries is caries lesions. And there are several manifestations of caries lesions clinically, from enamel all the way to cavitations into dentin. Why do we say that caries is a multifactorial disease? Well, I think we are all familiar with all the complexity of the caries disease process. We have several local factors, including the tooth structure and the several different surfaces we have on teeth: occlusal, aproximal, buccal, lingual, which will impact how the caries process will damage, will affect that specific tooth. We have biofilm being formed over the tooth surface. We have the frequency of sugar, the amount of sugar, the length of sugar exposure to the dental tissues and to the biofilm. We have several environmental factors, saliva being a critical one. Saliva being very important in terms of caries due to the clearance capacity of saliva. Saliva providing calcium, phosphate, and fluoride, if fluoride is available in our cavity, to promote the remineralization of tooth structures. And we also have several personal factors related to general health, oral hygiene, level of education, and socioeconomic status. If we are to look into more details into the caries process, we have here on the left side the process that will lead to damage of the tooth structures or demineralization. So we have biofilm, certain oral bacteria metabolizing sugar and releasing acid that will attack enamel, starting in enamel, and release phosphate and calcium back into the environment. And we have on the right-hand side, promoting remineralization, we have some of the components that I already mentioned: saliva, the clearance of saliva, the buffering capacity of saliva, saliva providing calcium, phosphate, and fluoride back into the tooth, promoting remineralization. So we have this cycle of demineralization and remineralization happening very frequently throughout the day, and is a very delicate balance. Whenever we have demineralization, the demineralization process outweighing the remineralization process, when we have the risk factors leading to caries development outweighing the remineralization factors leading to arrestment of lesions or progression of the lesions, we're going to have the first clinical signs of caries, beginning with enamel. And we can call it enamel lesions, white spot lesions, initial early lesions. And if these lesions are not arrested, if they are not controlled, we're going to have the progression of the lesions into cavitated lesions. So today we have greater focus on diagnosing, detecting these lesions enough early in the process so they can be arrested, they can be remineralized before they can progress into cavitation, in which most cases we need to restore that tooth surface back to anatomy and function. So there has been several systems to classify caries lesions. So classifying caries at a tooth level. The American Dental Association published in 2015 their classification system, which has been adopted by some authors and some associations, but it hasn't really taken off. Hasn't been really broadly adopted yet. But it's helpful to relate to this classification, especially today, because we're going to be talking about the ADA guidelines, and they use this nomenclature, they use this terminology. So according to this classification system, sound tooth surfaces will be surfaces that are intact, healthy tooth surface. And when we correlate that to the ICDI's criteria, which is the International Caries Detection and Assessment System, this sound tooth surface will be ICDI 0. Then we move towards increasing mineral loss, initial lesions being ICDIs 1 and 2, so lesions in enamel, where dentin has not been exposed yet. Then moving even further, we have moderate lesions, ICDIs 3 and 4, advanced lesions, ICDIs 5 and 6, always in relationship to the progression of mineral loss. And also it relates to what we would see clinically and radiographically. So according to the ADA classification system, these white spot lesions that we see here in this young patient would be considered enamel lesions. Initial lesions. We can also refer to as enamel early lesions, and the cavitated lesions into dentin will be the advanced lesions. So initial lesions, ICDIs 1 and 2, advanced ICDIs 4 and 5. In terms of surface integrity, this would be non-cavitated lesions and the cavitated lesions. In terms of lesion activity, whether the lesion is progressing towards further loss of minerals, or if the lesion has been arrested or is now inactive. These white spot lesions, they will be considered inactive lesions or arrested lesions, and the cavitated lesion here as active. And to determine activity is extremely important that we consider mainly 3 factors: the presence of plaque, heavy plaque around that tooth surface, hardness, and texture of the lesions, and that we do not consider color as a criteria for determining lesion activity. So today, the main pillars for managing caries disease are still the same that we know for many, many years. We need to have proper diet, decrease the intake of sugar. We need to have proper oral hygiene, so constant removal of the biofilm that is building up over tooth surfaces, and saliva, having good salivary flow and good quality of saliva. So I was talking about managing caries disease, and now we are moving towards managing locally the caries lesions, because these were the main topics of the two guidelines that we are about to talk about. In the past, the management of caries lesion was focused on restorative treatment, with the idea that placing a restoration could cure caries and could completely stop the caries process from progressing. Today, we know that this is not true. Today, we have more concern with preservation of the structure, with preservation of pulpal health and maintaining pulpal health. We are concerned with adopting non-restorative treatments, so treatments that involve removal of caries tissue and placement of a restoration, and association of non-restorative treatment with restorative treatment whenever the restorative treatment is indicated. So initial enamel non-cavitated lesions should not be restored, because they can be remineralized by non-restorative strategies. Cavitated lesions that are at risk for further progression, for example, this aproximal lesion, they should be restored. So now let's look into the two ADA guidelines for caries management. And to emphasize again, this guidelines, they were not related to manage caries disease at the patient level. They were related to managing caries lesions themselves at a tooth level. And there were two guidelines. The first one was published in 2018, and it relates to the evidence for non-restorative treatment of caries lesions. The second one was published this year and is related to guidelines based on evidence for restorative treatment of caries lesions. So the first guideline, as it happened with the second guideline, there was a systematic review and network meta-analysis that informed the recommendations of this guideline. So the ADA, the Council of Scientific Affairs of the ADA, they invited a group of experts in cariology, pediatric, and public health, and general dentistry that worked together with the ADA methodologists to do the systematic review, as well as to create the recommendations that are part of this clinical guideline. So the main clinical question for this first guideline was, what is the best available evidence on non-restorative treatment for caries lesions? So it is important that when you look at these guidelines, and I understand the guidelines can be a little hard to digest, especially the second one, which is pretty long. But it's important that you take a look on the systematic reviews that inform the guidelines, so you have a better understanding on what type of studies were included to inform the recommendations. So for the first one, we used the PRISM criteria and network meta-analysis, and this was important because they allow direct and indirect comparison of more than 2 interventions. The primary outcome was a lesion arrest or reversal, and all the different terminologies used by authors of published studies to designate what is arrested or inactive lesion. So there was a long list of nomenclature. And the secondary outcome was a diverse events. Which type of studies were included? Parallel and split mouth randomized clinical trials of any follow-up length, and studies where there was an active intervention being compared with another active intervention, or active intervention being compared with no intervention or placebo. Participants were children and adults. The type of caries lesions, they could be either non-cavitated or cavitated lesions in primary permanent teeth. There was a criteria for how they were assessed, the activity in terms of visual, tactile, and radiograph, the combination of these methods as well. And the interventions that were included were professionally applied or prescription products that were available at a time. in the US market. So there was a long list of intervention. The only exception was for the SDF, which at a time we were very interested in knowing more about the impact of SDF, knowing that it was just more recently approved in the US. But we also include, in terms of the SDF, the 12% concentration that at a time was not available in the US market. So we use the grade system to determine certain of inhabitants. And for those who are not very well familiar, we can assess evidence, certain inhabitants, starting with high and then moderate, low to very low. For example, in terms of direct comparisons, any randomized clinical trial that passes the eligibility criteria, right, starts as a high certain of evidence, and any serious or very serious issues of risk of bias, inconsistency, indirectness, imprecision, and publication bias decreases the certain of evidence. So we go from high all the way to very low. And this is important because it is how you're going to interpret these recommendations based on the level of evidence or the certain of evidence. With the studies that were included on this guideline, there were some major methodological issues, including incomplete and missing information, and that was part of why a lot of studies were excluded. Allocation concealment, which is related with randomization methodology, and risk of bias. So there were 44 studies published between 1984 and 2018 that made that were deemed eligible to participate and to be used to inform the recommendations. These 44 studies, they led to 11 clinical recommendations on approaches that were shown to be more effective in arresting and reversing caries lesions, both non-cavitated and cavitated. And each recommendation was specific to lesion type, tooth surface, and dentition. Again, given all the complexity of the caries process within the different surfaces, and also how clinical trials were reported by surface, there were recommendations specific to occlusal, facial-lingual, aproximal, and studies who combine all the surface. We also had that criteria for all coronal surfaces together, as well as root surface. So non-cavitated lesions, according to this guideline, non-cavitated lesions, we adopt the ICDIS 1 and 2 criteria, so initial lesions, and the cavitated lesions were the ones with advanced lesions, ICDIS 5 to 6. I'm going to try to break down this guideline, but it's important that and this was shown in this guideline, that every time you decide to apply a non-restorative treatment to arrest caries lesions, these lesions, they should be monitored over time. You cannot just apply any of these techniques and just let it go and think and not educate a patient on caries, or not having the monitoring process that allows you to verify the effectiveness of your technique. So 4 of the techniques or the treatments were deemed to be the most effective: fluoride, silver diamine fluoride, sealants, and resin infiltration. So to arrest non-cavitated lesions on occlusal surface, the guideline, the expert panel recommended the use of sealants in combination with fluoride varnish. So sealant first, and the application of varnish, or sealant alone. To arrest non-cavitated lesions or aproximal lesions, the recommendation was to use fluoride varnish every 3 to 6 months alone, or in combination with resin infiltration, or sealants alone, knowing that for sealants application on aproximal lesions, we have to separate the teeth, which can be in most cases, kind of technique sensitive. To arrest non-cavitated lesions on facial and lingual surfaces, the recommendation was to use fluoride gel every 3 to 6 months, or fluoride varnish every 3 to 6 months. To arrest cavitated lesions in any coronal surface, the best recommendation was for the use of silver diamine fluoride, 38%, using biannual applications. So to arrest root surface lesions, the recommendation was for the use of prescription toothpaste or gel, so 5,000 parts per million of fluoride being used at home at least once per day. And it is important that we realize that all these recommendations were based on the evidence we have from the published studies, right? So the best evidence that we found at that time was for the use of prescription toothpaste used at home once per day. That doesn't mean that using more than once per day wouldn't provide the benefit to caries arrestment for your patient. In terms of the restorative guideline, we had also a published systematic review informing the guideline. The guideline was a little bit more complex than the first one. So we started with the research question, what is the best available evidence on the use of direct restorative materials to restore cavitated lesions in teeth that are vital, so no signs of pulpitis, and non-endodontically treated. And then it evolves to our interest, and based on the clinical trials that we were seeing, our interest on answering a second question, which was, regardless of the restorative material and the means or the way that you remove the carious tissues, what is the most appropriate technique or approach for carious tissue removal with the same type of teeth, vital, non-endodontically treated teeth? So it became a relatively complex guideline, as you know, and I'm going to try to, again, break down to you briefly. So there were a total of 16 recommendations, clinical recommendations. 4 of those was related to caries tissue removal techniques, and this was specific to lesion depth, and 12 recommendations were for the use of direct restorative materials, and these recommendations, they were specific to tooth location and surface involved. When we talk about caries tissue removal techniques, it is important also to understand what's the nomenclature that was used to inform these clinical recommendations. So there were 4 types of caries tissue removal approaches that were published and described in clinical trials: non-selective caries removal, selective caries removal, stepwise, and no caries tissue removal. So selective removal, let's start with non-selective. Non-selective removal, it means complete caries removal. You're going to remove all demineralized carious tissue, and during the tooth preparation, go all the way to hard dentin. Selective caries removal, also called partial or incomplete, although I don't like this term, incomplete caries removal, is when you remove caries, you clean all the margins, and you may leave some soft, leathery, or firm dentin within the proximity of the pulp. Stepwise is when you remove the tissue, you restore temporarily, and you return to do more excavation. No caries removal, when there's nothing, no caries tissue is removed. And in this case, the techniques that were used in association with primary teeth and the use of preformed crowns as the restorative material. The caries lesions used on this guidelines were moderate caries lesions, or ICDIs 3 and 4, and advanced lesions 5 and 6. For the caries tissue removal recommendations, included to inform these recommendations was 1 systematic review and 12 clinical trials, and there were 4 clinical recommendations, 2 for primary teeth and 2 for permanent teeth. I think the most important information to take from this is that, in agreement with the consensus for the international consensus for caries removal that was published in 2016, this panel recommended that for advanced caries lesion, more conservative caries tissue removal approaches were associated with fewer clinical failures. So this is the best recommendation to remove caries tissue prior to use of direct restorative materials is to use selective caries removal. And this goes along with what we've been learning and teaching in cariology today, which is to preserve, to structure, to maintain pulpal health, to prevent pulp exposure. But at the same time, we need to establish sound cavus surface margin that will allow for the best seal of that restoration, for the best bonding of the restoration. Now, in terms of the direct restorative material guideline, following similar criteria of the first one, the PRISM method, the outcomes were, the primary outcomes were clinical patient relevant outcomes, all the way from a reporting of lesion progression, secondary caries, marginal discoloration, all the way to an acceptable marginal adaptation and many others. So I urge you to take a look and read all the primary outcomes that were included in this, the systematic review and meta-analysis, and then the guideline. The studies included were parallel split mouth and cluster design RCTs, again with any follow-up length. And that was one of the main issues informing this guideline, was the lack of long follow-up length. The use of direct restorative versus other direct restorative material as well. The participants were children and adults. The caries lesions could be primary caries or secondary caries. So replacement of restorations were clinical trials, including replacement of restorations, were also included. Cavitated lesions in permanent or primary teeth. Teeth with vital pulp, no signs of irreversible pulpitis. In terms of the interventions, the direct restorative materials that are available until this year in the US, including amalgam, resin composite, and all the subclassifications of resin composite, conventional glass ionomer, resin modified glass ionomer, compomators, and preformed crowns. For the recommendations, 38 clinical trials published between 1994 and 2021 were included in this guideline. And there were recommendations for primary teeth, recommendations for permanent teeth. In terms of primary teeth being anterior or posterior teeth, the best recommendations were for nanocomposite and hybrid resin composite, conventional glass ionomer, and resin composite or resin modified glass ionomer. And when we go to the posterior teeth, removing the amalgam, pretty much all the other restorative materials were deemed as acceptable and the best available evidence for those. For permanent teeth, we have the separation between coronal and root surface. For anterior teeth, the best recommendation was for the use of nanocomposite or hybrid composite when we are dealing with class 3 restorations, conventional glass ionomer, hybrid resin composite, or resin modified glass ionomer when we are dealing with lingual pits, class 1 on anterior teeth, or class 5s. For posterior teeth, being a class 1 or class 2 amalgam, resin composite, resin modified glass ionomer, they were considered the best recommendations. For posterior teeth, class 5, conventional glass ionomer or resin composite or resin modified glass ionomer. For root surface, the glass ionomers were the best recommendation, resin modified or conventional glass ionomer. So one of the main issues in this guideline was that in most clinical scenarios, evidence did not show important differences between direct restorative materials to suggest that one option was superior to another option, right? So despite all the support for research, all the money that has been involved in supporting clinical trials and clinical research, we still had a huge issue on finding studies with high evidence. So if you look at the tables that we have in the guidelines, and when we look at the same criteria, using the grade criteria for certain of evidence, a lot of the evidence were deemed as very low. So the recommendations could only be conditional. And this has to do with the major reporting issues that we have for the clinical trials with, again, incomplete or misinformation. In this case, even lower event rate for outcomes related to clinical trials and high risk of bias. So one of the things that we, one of the take-home messages of these two guidelines, right, something that we already know, but it became even more obvious, is that we have an urgent, in dentistry, we have an urgent need to develop evidence-based clinical practice guidelines, not just for caries management, but for everything. But where is the evidence? We can only provide recommendations when we have evidence. And strong evidence depends on high quality of designing, conducting, recording, and reporting clinical trials. And this is still a major issue, not only in the US, but globally, on how these clinical trials are designed, how they are reported, how we can extract the data from these clinical trials. So in terms of risk of bias, it's pretty clear that to reduce risk of bias, clinical trials need to be used more acceptable methods, especially for allocation concealment. And that was one of the biggest issues we have in finding good evidence to inform these guidelines. But it's still, with the evidence that we have, I hope this can be informative for clinicians on making their restorative and non-restorative clinical decisions, as well as for patients, policymakers, and stakeholders. So thank you.